Okay, we'll make a start. This is the third lecture on epidemiology and research methods. And yesterday we talked about case control studies and particularly odds ratios as being the right measure of association in odds ratio in case control studies. And we talked about the 95% confidence intervals as being the measure of our confidence that the point estimate of the odds ratio is correct. Today, I want to talk a bit about cohort studies and how they're different from case control studies, and how they can be used to address different questions. So, I mean, a cohort is basically a group of people who have a shared characteristic, and so that could be virtually anything. But that's what the definition of a cohort. And cohort studies, the primary thing about them, unlike case control studies, is cohort studies are always prospective, right? They can be just observational, where you observe a cohort over a long period of time and find out what happens to them, or they can be interventional studies where you might intervene halfway through the cohort or some way through the cohort, or there might be a series of interventions that leads to a change, or is exploring whether or not there's a change in the outcomes that you're measuring in the particular cohort. But a cohort is always a detailed longitudinal recording of data, right? Unlike a case control study where usually, not always, but usually the data are recorded at, usually one point in time, and then that's compared with a group of children or patients that don't have the particular disease. So the large difference being that when you're choosing case control studies, you start with cases like people with the disease and then choose the controls. With a cohort study, you start with a group of people with a shared characteristic who might be at risk of a disease, and follow them up to see if they get the disease or get the adverse outcome or whatever it is. And what you're trying to do in a cohort study is to identify risk that a certain exposure will lead to a certain outcome. Okay, the risk that a certain exposure might lead to a certain outcome, and it might not be just one exposure; it might be more than one exposure. Sometimes it's the cohort has been exposed beforehand. So, for example, there's been a cohort studies done of people who were exposed to the Chernobyl nuclear disaster and following them up to see what happened to them. That's a cohort where the very dramatic exposure occurred before the cohort was identified. But many cohort studies of studies of otherwise normal people who might be exposed to something to see if they get a risk factor. I'll try to explain with some examples. As I said, the direction of the study is always forward in time. It's always prospective. And well, it's almost always prospective. The difference between a cohort study and a case control study is that a case control study doesn't allow you to determine the incidence of a disease, because you're choosing the cases at the start. So you don't know what the incidence of it is unless you study a source population from which they came, right? Whereas with a cohort study, you can determine the incidence of a disease because you're following the patients or the population longer term, and in that population, you'll know the incidence of that disease, right? If it occurs and when it occurs, right? So the case control, a cohort study probably provides a bit better evidence for cause and effect relationships, a bit better, mostly because it's prospective and mostly because you can adjust for confounding along the way. Although it's not perfect, it's not like the gold standard, which is a randomized trial looking to see whether it's a case control study is a cohort study is not randomized. It's a longitudinal study, right? But there are many sorts of cohort studies, and the most common one is like a birth cohort, where you take a group of children who are born at a particular time, like born at a particular day or in a particular year, and then you follow them longitudinally. That's a birth cohort. So some examples of birth cohorts, like there's a study in the UK called 7 Up. You might have seen it. So it's actually become a television program, and every 7 years they follow these group of well, they were children, they were babies to start with, and they see what actually happens to them throughout life. This is a very, very long longitudinal follow-up study. It's not primarily focused on health. It's about trying to describe their social outcomes, social, economic, employment, those sort of outcomes. And it's more made for television rather than made for science, but it's quite a famous cohort. It's an age cohort where all the children who are now well into I think they're about well into their 70s now, because there's been 10 or 11 different programs on it every 7 years. And so it follows people up. It's not, as I said, it's not made for science. It's made for maybe social sciences. You couldn't determine anything about incidence of particular diseases in this cohort because they're all too small. But there are some other cohort studies that are like following up an adolescent cohort. So they've taken adolescents and followed them up to see, again, what happens to them in terms of social and economic and vocational and educational outcomes and that sort of thing. There are some cohort studies that are like a school class cohort, so taking a particular school class and then following them up. Some of the most famous studies have actually been professional group cohorts, and I'll talk a bit about some of those. You could have a cohort study that's like a disease cohort, so following up children with epilepsy or children with HIV or children with TB, and following them longitudinally to see how they go with their treatment, what how good a control of their disease they have, whether they improve or not. And I think longitudinal disease cohort studies are actually very valuable. They're really useful because we often don't know. We sort of only know outcomes as to what happens to children at the time of discharge. But knowing what happens to them, at the completion of their treatment and how they go is actually quite an important thing. There are other like social group cohorts. There's like, for example, you could imagine a cohort of like adopted children that are followed up long term, or a cohort of HIV exposed babies to follow them long term. They would be interesting cohorts. And then there are other cohorts that are like before and after cohorts, whereas you just identify a group of children with a particular characteristic before and after an intervention, right? So there's a number of ways to look at cohort studies. They have some advantages, cohort studies, because they can, if they're done well, describe the varied influences of a group of people over time, what influences their outcome if you measure it well. And they can also, if they're done well, can measure like multidimensional effects. So not just measure medical aspects and diseases, but the effect of social and economic and educational influences on disease and later outcomes. I'll again talk about some of the famous cohorts that have done this. It's good because it's longitudinal, so you can describe the natural history of a condition over time and whether, for example, it responds to treatment or doesn't respond to treatment, or recurs over time or recurs multiple times, relapses, etc., and the influences on that particular disease in a disease cohort usually. And again, you can identify the incidence within the cohort, because if you're looking for a disease within a cohort, not a disease cohort, but if you're looking for a disease within a cohort of, a birth cohort, then you can define the incidence of the disease in that particular cohort. They have some limitations in that they take a long time to do, and you often get lost to follow up. So you can imagine trying to follow a cohort of children here, there'd be a lot of loss to follow up. There's been a couple of good cohort studies done by some of the trainees over the years. I particularly think Annette Garay did a really good study of a cohort study of very low birth weight babies in Vanuatu, And she followed them up. It was only a year or 18, maybe 18 months she was able to follow them up, some up to 2 years. But that told us a lot about what happens to these babies. And again, it didn't have to be a big study, like the sort of birth cohort generally has to be quite large, whereas a disease cohort, like very low birth weight babies, it didn't have to be that large to yield very useful information if you follow patients up over a long period of time. I think her study was only about 30 very low birth weight babies, but she followed them up for a long time. She went to their homes, to their outer island villages, and did developmental assessments on them and assessed their growth and development over that 12 and 18-month period. And I think that told us a lot about what happens to these babies. They are time consuming, and they yeah, as I say, you can get lost to follow up. But even if you get lost to follow up, that can be useful in itself, because it can tell you which children are less likely to be easy to follow up and that sort of thing. It's a cohort study with follow-up, like a disease cohort, is always active follow-up. You always have to try to follow them up and go out and find them, etc. Yeah. Okay. Right. I won't talk about this vitamin K study, but there was a famous study in Scotland that was a cohort looking at the effect of vitamin K on a whole variety of different conditions, and they found in that cohort that vitamin K had a link to childhood leukemia. That proved to be quite inaccurate over time, not relevant. But it also led to intramuscular vitamin K being withdrawn in the UK for a while, and then the rates of hemorrhagic disease of the newborn rose again, and then there was better long-term studies done that proved that it wasn't actually a risk factor for leukemia. So iron vitamin K was reintroduced. This might be more useful, and that is there's been some very I think very important longitudinal cohort studies that have been done. And one of the first ones was a study of British doctors, 40,000 British doctors over over 50 years, and it's called the Bradford-Hill study. You might have heard of Bradford-Hill. He was a famous epidemiologist, but he started this British doctors study. You might wonder why you'd study British doctors. The main reason, there's also, like, in a similar way, there's a UK nurses study as well. It's called the Nurses Health Study. That's still going. It's 120,000 nurses, mostly women. I mean, I think maybe, mostly women, and it's identifying aspects of cardiovascular risk. There's a reason why health professionals have been studied in these studies, and mostly it doesn't relate to them being anything special, but they're all registered. And the point that they're registered means that they can be followed up. That's really the main advantage of doing that. And so if you tried to follow up truck drivers or something, it'd be very hard, to be lost to follow up, even though they might be more instructive in terms of what happens, in terms of disease. But the British doctors study was interesting because in the 1950s, many of the British doctors smoked. And so many of them got lung cancer, in the subsequent decades. And it was another strong piece of evidence that smoking caused lung cancer. So these days, of course, you wouldn't be able to identify that in many doctors, because not many doctors smoke. But in those days, smoking was quite common. But identified that doctors who smoked had a much, much higher risk of carcinoma of the lung. There's been some other good cohort studies. This one called Mandela's Children was a very good cohort study that of 3,000 births that occurred in 1990. And it's called Mandela's Children, not because they're his children, but because he was released from prison that year. Okay, that's the year he was released from prison. So they launched this study called Mandela's Children, and that has yielded a lot of information about really what happens to children in South Africa in those times, in terms of disease, in terms of social outcomes, economic prospects, that sort of thing. So that sort of study is really, really useful. They've studied they studied these babies born in 1990 for 20 years. So it finished in 2010, and I think it was quite a useful study. There's a similar study in Dunedin in New Zealand going on at the moment, studying 1,000 births, consecutive births, and just looking at those children over time. You can imagine some, studies that could be done in PNG, a birth cohort to adolescence or a disease cohort. They're all possible, I suppose. And in some ways, that might yield quite useful information about, what happens to children. But again, the population is so diverse that if you study one section of the population, it's not necessarily generalizable to the other section of the population, but it's worth thinking about. It does take a long time. I wanted to just touch on what when we talked about case control studies, I said that the outcome you often measure as a measure of association is the odds ratio. In cohort studies and in randomized trials, the measure of association or measure of effect is usually what's called the relative risk. Okay, and it's very much like the odds ratio. In fact, in many studies, if you do both a relative risk and an odds ratio, you find them rather similar. But there are some differences, and they depend on the prevalence of the disease, right? The prevalence or the incidence of the disease in that population. Remember, I said case control studies can't identify the incidence of disease, whereas and neither actually can randomized trials, but cohort studies can, because you're following a population usually that doesn't have the disease to identify when they get the disease and then look at exposures to that type of condition, right? And so this is the relative risk. It's a little bit different to, remember the formula for the odds ratio was a bit different to this. This is A on A plus B divided by C on C plus D. It's the risk of something, the risk in the exposed subjects divided by the risk in the unexposed subjects, right? It's similar to the odds, but it's just a bit different. All right, but the 2x2 table is structured similarly, A, B, C, and D, and you can just put in the numbers. And the relative risk takes into account the prevalence within a population, whereas the odds ratio doesn't. They're the only differences. But you just need to know that for a case control study, use an odds ratio. For a cohort study, use a relative risk. I want to just give an example of a cohort study that's a little bit different. It was a before and after cohort where the researchers looked at an infection control intervention halfway through, right? And so it was looking at a population in a hospital ward in Indonesia before an infection control intervention, and then a population afterwards. So it's two cohorts that in the middle there was an infection control intervention. And I want to go through how you do the relative risk. This is the study, and it's called Reducing Hospital-Acquired Infections and Improving Antibiotic Use it was in Indonesia. And it was published about 10 years ago. But the intervention, it was an intervention study of two cohorts. So the before cohort, they just did what they usually do, right? It was a before and after study. They just did what they usually do. They had not very organized hand hygiene. They had not very structured antibiotic stewardship, and they didn't really have guidelines for aseptic procedures. So the before cohort was looking at the frequency or the prevalence of nosocomial infections in before, and the after cohort was looking at the nosocomial infections after that intervention. Does that make sense? Looking at two cohorts, and it's following children right to the end of their admission, but it's following a lot of children right to the end of their admission over a 12-month period. So 12 months before and 12 months afterwards, right? So two cohorts that go each for 12 months and looking at the relative risk of having a nosocomial infection if you happen to be in the era where that better infection control was. Does that make sense? Yeah. So yeah. Okay. So these are the data. I pulled it out from the paper, and in the before the intervention, there were 1,227 children, right? And of those, 277 had a nosocomial infection. And it was a good study because they defined nosocomial infection in a very detailed way, and there was a clear definition of lots of different types of nosocomial infections, and they used microbiology and bacteriology to identify nosocomial infections. So it was a very tight, I would say, definition of nosocomial infections. And that's important because you don't want to have like ascertainment bias. There has to be, if you're doing a before and after study, then you need to be sure that your ascertainment of the outcome is exactly the same before as it is afterwards. Otherwise, there's bias introduced. You know, you might think that the infection control intervention is going to work, so you're biased and you don't identify as many nosocomial infections. But this study was very good in that the definition was very tight and objective. So in the post-intervention cohort, there was 1,419 children and 123 had a nosocomial infection. So even just eyeballing the data, it looks like there's a reduction, doesn't there? But there's a few more in the post era. Not surprising. There's a few more children admitted, not many more, but a few more, but seemingly a lot less nosocomial infections, right? And so throughout that period of time, there were 2,646 children in the study overall, those two cohorts, and 400 of them got a nosocomial infection. But as you see, that more than twice were in the before the intervention, right? Somewhere I've got the. Oh yeah, here we are. Oh, all right. Maybe you can try to do the relative risk in this circumstance. Can you have a try at that? It's A on A plus B. You need a calculator for this one. What did you think, Ray?
About 0.3997 or 0.4.
Around 0.4. Yeah. Is that what you others got? So it's 123 divided by 1,419 in brackets, divided by 277 divided by 1,227, isn't it? Yeah, in brackets again. Right. So you do the brackets first, and then you do the, yeah. So it's the risk of the risk ratio is the risk of having the disease, which is a nosocomial infection, if you were exposed to the intervention, compared with the risk of having the disease if you weren't exposed to the intervention. Yeah. Yeah. Does that make sense to you? Yeah, that's right. Okay. All right. So again, I won't go into this too much because I mean, most of you probably won't do like these before and after cohort studies, but we might do that. I mean, Michael Landy did a before and after study of the malnutrition I talked to you about. It didn't involve too much relative risk calculation, but you can see how it's possible to look at a cohort of children before and a cohort of children afterwards, or a group of children before and a group of children afterwards, and to define again the incidence of nosocomial infection in that population, in each population, because the incidence is like 123 divided by 1296, isn't it? Times 100. That's the incidence in terms of percentage incidence of nosocomial infection. So it's possible to define the incidence rather than a case control study, which would have involved taking children who had a nosocomial infection and then a control group, right? This is a neat way of doing a study, and unlike other very longitudinal cohort studies where you don't have an intervention, this only took 2 years to do. Yeah, so it's possible to do, and it showed that this intervention clearly is effective. You know, so the way you would, yeah, clearly is effective. So how would you interpret it if the relative risk is 0.4? I think it was 0.42. Is that right? Or 0.4, 0.39, is it?
0.39.
Okay, 0.39. If the relative risk is 0.39, then how would you interpret that in plain language? That's right. That's exactly right. Or another way of saying it would be that the intervention led to a 61% reduction in nosocomial infection, a 60% reduction in nosocomial infections, isn't it? Yeah. Does that make sense?
Yeah.
Because your relative risk is 40% and 0.4. Yeah. Okay. Okay. So there's, with either case control and cohort studies, there's a bit of a risk in assigning causation when sometimes there's lots of other things going on. So I guess I wanted to just talk to you about like bias and confounding, and also about rules for assigning causation. So there's a certain, like with this intervention study, that's different, the nosocomial infection study, because you've done a deliberate intervention. But when you're following a cohort over a long period of time and making observations about various exposures, then it's you're not sure that those exposures actually led to the disease, right? But sometimes when you see an exposure, like see what seems like an association, you need to have some stronger evidence that there's an association, right? I won't talk about this at the moment, but both case control studies and cohort studies can identify associations, but to say it's a causation, then you need to have some rules. And this was Bradford Hill's rules, again, during the British Doctors study, but also in many other studies that he was involved in. There has to be some, it's obvious, but there has to be a temporal relationship. That is, the cause must precede the effect, right? So the thing you think is the exposure has got to have happened before the disease occurs, right? That's the first thing, temporal association. Secondly, there has to be some, what we call plausibility. That is, there's strong biological plausibility that smoking causes cancer now, isn't there? Because we know the effects of smoking and the chemicals in smoking. We know the carcinogenic effects of those chemicals. We know the effects on the lining, the mucosa of the bronchial tree, for example. So there's biological plausibility, whereas some associations like intramuscular vitamin K and leukemia, it's hard to see the biological plausibility in that. Yeah. So plausibility doesn't have to be biological. It can be just consistent with existing knowledge or other evidence that that helps you join evidence together, right? There has to be consistent and has to be reproducible. So the same outcome, the same exposure has to be identified in several studies. It's usually not just based on one study. So reproducibility is important in any sort of research. You're trying to, sometimes we think that you reproduce a study and that's a waste of time. But actually, if you reproduce a study and find the same answer, then you're sometimes you're adding to the strength of the evidence for that particular hypothesis, right? there has to be like some strength to it. And that means sometimes if you find like a weak relationship or a weak association based on a weak odds ratio, right? A weak odds ratio or a weak relative risk, it only just exceeds 1, then it might be that is not a factor. It's really found by chance alone. And if you did another study, then it might overlap 1 and your odds ratio might overlap 1. And then you actually don't have a causal relationship, right? We saw a lot of examples yesterday of confidence intervals that overlapped 1. Well, there's no proof of a causal relationship there. Yeah. It's also as part of especially the identifying causation, there has to be a dose response. And you can imagine that smoking, for example, is a good example of dose response, isn't it? They knew not only were those doctors who ever smoked more likely to get lung cancer, but the doctors who smoked more on a regular basis were more likely to get lung cancer than those who smoked less, right? So in those days, there were some people, cigarettes were so cheap, there were some people that were smoking like a packet or 2 a day. It's extraordinary, isn't it? But that they clearly, the more cigarettes you smoked per day, then the higher risk of lung cancer, a dose response. There's another good example I might show of mercury poisoning and a dose response. And it helps if it has some reversibility. That is, if you remove the exposure, then the risk goes down, right? And that can help add to it doesn't always go down. So your risk after some like radiation exposure, your risk of getting longer term cancer may still exist because of the intensity of the exposure at one point in time. But for some diseases, then there'll be reversibility to the causation, or reversibility to the risk of getting the disease. So these things: temporal relationship, biological plausibility, consistency and reproducibility, the strength, the dose response, and reversibility. They're the rules for the evidence of causation. And that you can use, I think it's good to know these because you can use them whenever we might see a phenomenon that we think, this caused this. Then you can think to yourself, well, does it have those rules? You know, like often we jump to conclusions when we don't apply these sorts of rules, right? Okay, so whenever you see an association between a possible cause and a possible effect, you should think to yourself, well, could it be due to bias? Could it be due to confounding? Or could it just be a result of chance? Or is it indeed causal, right? And again, if you apply those rules, then you get over the bias and confounding because it's been reproducible in different populations, because there's a strength of an association, there's biological plausibility, there's a dose response and a temporal relationship, then it makes it much less likely there's bias and confounding. Whereas bias and confounding can apply a lot to like a single study where someone finds something and they think that's related. A little bit like yours, Dasha. I mean, I must say, in the praldehyde question, there may be some confounding there, and even though we've looked for confounding in terms of trying to understand the possibility that it's related to just the child being sick with seizures to begin with, and there still seems to be an association. I would say it's not in any way confirmed, is it? It's been identified in one particular study, but I think it still remains a very interesting observation that probably should be followed a bit further. Yeah. So there's a very famous condition that occurred in Japan back in the 1960s, and this was a condition that it led to only a case control study could identify this. And it was many people in the early 1960s were around this place called Minamata Bay, were dying from what was thought to be infectious meningitis. They were getting severe encephalopathy and dying, and they're mostly adults. And a case control study was done of this population, they looked at those who had this encephalopathy and had died, and they looked at people who hadn't. And they found that, well, firstly, that there was a cluster. The cluster was around this place called Minamata Bay. And they were mostly families involved in the fishing trade. So there was, instead of those not, who didn't get this, they were almost all involved in the fishing trade. And those who ingested, like, ate only small quantities of fish, they didn't get sick. So again, it's a dose effect. Those who ate more fish got more sick. And then they looked in the fish to see if there was any chemical there, because they thought it might be due to mercury poisoning, and they found mercury. So again, you've established biological plausibility, you've established a dose effect, you've established like a temporal relationship, eating fish that were caught in the Minamata Bay and getting the encephalopathy. And then it was identified as methylmercury poisoning. So the point was that all of these principles were applied to this case control study to go from just a causal, an association that was observed to causation, right? Proving causation. Okay. I just wanted to briefly touch on bias and confounding, just one slide on each. And there's lots of different sorts of biases. We think of bias as being something that's like a mindset. We are biased on something, but actually, there's lots of inherent biases, systematic biases that a study can have. And for example, there's measurement bias, selection bias, and responder and recall bias. I talked a bit about recall bias. Remember when I said about when you're doing the demographic and health survey, and they asked that question about, has your child had acute respiratory infection in the last 2 weeks? Remember, we asked 2 weeks because if you ask in the last year, well, it'd be too hard to remember. So you'd have a problem with recall bias, right? Measurement bias is when sometimes if you don't have your definition very tight, then it's possible that the person who's doing the measurement, if they know the exposure, might be more likely to ascertain the outcome even when it didn't exist, right? So it's a subconscious, can be a subconscious thing. If you happen to think that you might be able to, you might make the diagnosis of the outcome when actually there wasn't when in the, say, the unexposed people, you didn't make the diagnosis, right? So that might be a way. And selection bias is often when you choose your population to study, it's important. That's why, for example, in case control studies, you have to have a really well-matched control group, right? And that eliminates to some extent selection bias, right? Because if you choose a well-matched control group, then you're not choosing children for some reason who have certain exposures, right? It's got to be matched in terms of everything else but the disease, right? Confounding is a little bit like bias. I think there's a good example here where there were some studies done many decades ago that apparently showed that the observation was that coffee drinking led to pancreatic cancer. And this was published some decades ago, and it was an observed association. But when it was looked into more, it was found that those people who drank coffee were more likely to smoke in those days, right? If you drank coffee, you're more likely to smoke than if you, say, drank tea. And it was actually the smoking that was linked to the pancreatic cancer, not the drinking coffee. So that became, again, a more likely explanation. And that thought that coffee drinking might lead to pancreatic cancer was then eliminated. That's where a non-causal association between like two factors can lead to confounding. So the smoking was confounding the observed association between coffee drinking and pancreatic cancer. That's what we mean by confounding, right? Okay. The only ways you can control for confounding, which are quite common, is either at the design stage of your study, and if you're the best way to control for confounding is by randomizing patients, right? But that again is a different sort of study, a randomized trial. But in a case control study, you're trying to control for confounding by matching. As I said, matching for age or sex or social class or other potential confounders in a case control study. And then you can also control for confounding when you're doing the analysis. And that's usually by a couple of statistical tests that doing a multivariable analysis controls for confounding, all right? You saw an adjusted odds ratio controls for confounding somewhat. The same analysis we tried to do, Dasha, of your study to look for other risk factors for death in those patients with pneumonia. You might think about some other factors you might want to control for to see if the strength of the association of praldehyde still stands up, right? So you can do statistical adjustment, and you can also do stratification of patients, which means that that's in a randomized trial usually. So to do that, instead of randomizing every patient, you break them up into groups and you randomize within groups. So you might randomize. So for example, a randomized trial that involves several hospitals, they might stratify for that given hospital, right? So they'll randomize within that hospital and randomize in another hospital rather than having like 3,000 numbers. They'll have 600 numbers for each hospital, for example, for 5 hospitals, right? Yeah. Okay. I think the main things is to know what a cohort study is, what the relative risk is, how you calculate it, sort of, and understanding about the difference between association and causation, right? And the rules for causation. Right? I wanted to just briefly touch on randomized trials because we talked a bit about it, and randomized trials are like the gold standard for attributing risk or benefit of any intervention. So the case control studies and cohort studies, they can't really do that, but a randomized trial can. And you can test using a randomized trial a new intervention or a new drug, a surgical procedure. They're probably best good at measuring relatively simple things. It's hard when you've got a very complex intervention to do it in a randomized trial. Sometimes it can be done, but it's sort of hard to do that. They don't have to be medical interventions, and there've been some good randomized trials of social interventions, like school nutrition programs, for example, done in a randomized way, showing that growth is better and cognitive performance is better in when you've got a school nutrition program. And again, there's been big studies in South America, particularly, randomizing schools to having the nutrition program or not having it to start with, and then seeing whether things improved, right? So that's what's called a cluster randomized trial. The main thing about a randomized trial is it eliminates bias and confounding, and you can measure the incidence of an outcome depending on if you randomize, not if you're randomizing patients, but if you're randomizing populations, like randomizing schools or randomizing groups. However, whenever you're reading a randomized trial, you need to think, is it valid? Is it applicable to my situation? Is it a difference there's a difference between an efficacy and an effectiveness study, and it's a subtle difference, but an efficacy study is like where everything's tightly controlled, right? This is what most people do, a very tightly controlled study. An effectiveness study is where the intervention is applied to a population. It's put into a population. So a good example of this is the Haemophilus influenzae vaccine. When that was first introduced, there was a randomized trial, efficacy trial done in the Gambia, and it showed that there was much lower risk of meningitis if the children were randomized to the Hib vaccine. Then the country was very smart. They did a a large-scale effectiveness study where they introduced it into the entire population and then measured the effectiveness on it in change in rates of Haemophilus meningitis, and it almost eliminated Haemophilus meningitis. And that was an effectiveness study because it was in the real world, right? Real world compared with a sort of artificial like study environment. Does that make sense? Yeah, yeah. When you're doing a randomized trial, it can be tightly controlled. Whereas when you're in the real world, then not everyone gets the vaccine, and you can still see what happens in the real world, right? And what they found in this study, in the effectiveness study, is that even if you had a 60% vaccination rate, because that's what they achieved. So I think it was 66% in their effectiveness study, it almost eliminated Haemophilus meningitis. Whereas in the randomized trial, all the children that were randomized to the vaccine got the vaccine. Does that make sense? So that's like a bit artificial because you almost never get that within a population. So that's why an effectiveness study to follow an efficacy study can be very useful, right? It can show what the effect of the intervention in the real world. And it can also show about sustainability. Some randomized trials are really logistically hard to do outside a trial situation. And you need to do an effectiveness study to see, oh, would it really work in a real world situation? Right? Okay. So you need to know something about randomized trials, but not many people will do them. But it's useful to know because we read them, and it's useful to know how to read a journal article and how to critique a randomized trial. And this is a way that you can look at a randomized trial. And I always think that if I read the abstract of a trial and I could fill out this template, then it's usually a well-done trial, and it's usually a well-written trial, right? And so you can think about, it's called PICOT or PICO, and you look at the researchers have to have defined the population, right? In children with disease X or at risk of disease X, the intervention, does treatment with this new drug or this giving this vaccine, does it compared with the gold standard, and whatever the gold standard is, that's the comparator, intervention, the comparator, does it improve some sort of predefined outcome that they've already defined? And does it and over what time period does it do that? All right. And so you can think in that efficacy trial I talked about in the Gambia, does giving HIV vaccine to Gambian children reduce the risk of Haemophilus meningitis over a 3-year period? They looked over about 3 years. And clearly they found it had a big effect because the HIV meningitis only occurred in children who didn't get the vaccine, right? So it proved the effectiveness of the vaccine over that defined period. So you can use this template to assess the quality of a randomized trial, okay? There's a couple of types of randomized trials, and you can have an open trial where everyone knows the intervention, or you can have a single blind trial where usually the people who are giving the intervention or the people who are assessing the outcome don't know the intervention. And then there's a double blind trial where neither the people receiving the intervention nor the people administering the intervention nor the people assessing the outcome actually know which group the patients were in, for example, right? And the gold standard is a double blind trial where nobody knows until it's unmasked at the end, right? But for some interventions, it's very hard. There's been, randomized trials of certain therapies that you can't be blinded to, for example, because they look very different. You can't have a placebo, for example. Yeah. Okay. The advantages of a randomized trial, like I said, you can eliminate bias and confounding. You can get a strong evidence of a causal relationship, whereas with case control and cohort studies, it's a little bit harder. You can it can be used to study multiple outcomes. So not only can it study benefits, it can also study harms. All right, a randomized trial can study the risks of an intervention. So you might have an intervention that might have a strong benefit, but if it carries side effects, you'll identify it in a randomized trial, usually. The problems are it takes a long time to do it, they're expensive. There are sometimes ethical issues depending on how they're done, especially if you need to be clear that the control group, the group that aren't getting intervention, still gets the best possible treatment. You know, you only do a randomized trial when you have what's called equipoise, and that is you don't know whether or not the intervention will work, right? You don't know. If you knew, then it'd be unethical to randomize patients to the control group, right? If you knew. But if you don't know, then you have what's called equipoise, okay? A randomized trial tells us the average effect in a group of children. And this might be a bit hard to understand, but it tells you the average effect. It doesn't tell you necessarily which within subgroups or within individuals will the treatment work for you, right? And so now increasingly there are randomized trials that are stratified to certain subgroups, and that can tell you within that subgroup, does it work, right? So there are ways of having a bit more knowledge than just the average treatment effect. The randomized trial doesn't necessarily tell you how an intervention works or even in what context an intervention will work, because you're creating a context by doing the trial, right? It's good studies, but not always easy to do, and they don't tell you everything. So this is, as I said, this is a good template. I wanted to just show a simple randomized trial that hopefully will make some sense. This was a good one from a few years ago, and it was called the efficacy. It was from 9 hospitals in Africa, and it was a randomized trial of 2 treatments for status epilepticus. Right, one was sublingual lorazepam, and the other one was intrarectal diazepam, right? And so they randomized patients to one or the other, right? It was a trial in pediatric emergency departments in 9 hospitals. There was 436 children, and again, they were aged 5 months to 10 years with convulsions persisting for more than 5 minutes. So they've clearly defined their population, right? You've got to be a child between 5 months and 10 years. You've got to have convulsions persisting for more than 5 minutes. So it's not every child with seizures, and it's not every child with prolonged seizures, because there was an age, an age inclusion criteria. And their outcome was cessation of seizures within 10 minutes. Again, they've got an outcome within 10 minutes of the therapy. And again, they've got an outcome that can be accurately measured, isn't it? So they thought that if the seizures stop in 10 minutes, that's a good thing. And what they found was that sublingual lorazepam was 56% efficacious in stopping seizures at 10 minutes, and intrarectal diazepam was 79%. Does that make sense? Right. So which one was more effective? Intrarectal diazepam seemed to be substantially more effective. And I won't show the statistics, but they did an odds ratio on that, right? And the odds ratio was 2.95. So remember, that's the point estimate, and you need to look at the confidence intervals and see if it overlaps 1. And does it overlap 1? No, it exceeds 1. Remember, the lower limit of the confidence interval exceeds 1. And so it's almost 2 to 4, and it's 2 to 4.5, isn't it? So that means that intrarectal diazepam was almost 2 times as effective as sublingual lorazepam, right? And their p-value was significant, because you can see it doesn't come close to 1, right? 1.9 is nearly two times, right? Nearly twice as effective, right? 90% more effective, not 100% more effective, but 90% more effective, right? Okay. So they concluded that sublingual lorazepam was less effective in stopping seizures than intrarectal diazepam, and so therefore you'd prefer giving rectal diazepam. That's all. Yeah. Okay. So I think it's a good study to understand the PICOT framework. So let's try to do that with this study. So in children, the population is children aged 5 months to 10 years with convulsions lasting more than 5 minutes. Does treatment with lorazepam, that was the intervention. The gold standard was compared with rectal diazepam, increase the probability of cessation of seizures over 10 minutes. Remember, 10 minutes is the time dimension, right? And they also measured some secondary outcomes. But you can see from that it's a study, and it was very clearly written. I've just reproduced the abstract here. This is largely the abstract with some words taken out, but you can see from that it's possible to fill out a PICOT sort of template and see what the outcome, see what the quality of the trial was. Right? If you're doing this, you should also, like some of those other things I mentioned, such as checking to make sure that either it was a blinded trial or not blinded, that those who ascertained the primary outcome were not aware of the therapy the child received. That would be important. So because that would eliminate bias. So each year there are hundreds of randomized trials that are published, and some of them are good and some of them are not so good. I thought this one was quite a good one. So yeah. Anyway, so today we've talked about cohort studies, and we talked about randomized trials. We talked about relative risk being the appropriate statistic, the appropriate measure of association in a cohort study or a randomized trial compared with a case control study. And we've talked a bit about going from an observation of association to causation, and the sorts of rules you need to apply to an observation to make it more likely to be causation. So again, they were things like a temporal association, a dose effect, the strength of the association, the reproducibility of it, potentially reversibility of it when you remove the exposure. So they were the biological plausibility. They were the things that you need to think about to determine whether it's just an association or whether there's stronger causation. Okay, I'm going to stop now, and if you've got any questions, then please ask.